Thank you very much, Dr. Ahmed, for the introduction. I will be talking about musculoskeletal interventions in cancer patients. First off, I'd like to thank Professor Mohammed Abul Huda, President of the conference, Professor Sahar Al-Fi'i, Chair of the Department, and Professor Gamal Niazi for the invitation to present. My objectives will be to give an overview on how interventional radiology can help patients with bone or musculoskeletal tumors and give an overview of these IR procedures that we offer. I think the first role that we always play is diagnosis, and it's very central to our practice, is the biopsy and how not all biopsies are the same, whether we're dealing with a metastatic lesion or a primary tumor, the approach is a bit different. For metastatic lesions, most of my presentation will be through examples and cases. This is a 64-year-old male with prostate cancer that was local, and he had rising PSA after treatment. And this is a PSMA PET showing an avid lesion in the left scapula with a CT correlate, which makes our life easier for the biopsy. You see that there's a cortical defect, which we can use to access to get the sample. The patient was positioned in the appropriate position. The grid was placed. This was done under CT guidance, and this was how we approached the biopsy to get the sample. We did not need to use a bone biopsy needle because there was a cortical defect that we were able to sneak through, get the sample, and clinch the diagnosis. Another similar lesion, this is a 65-year-old female with anal SCC that had an incidentally detected pubic bone lesion on imaging, and that would affect her prognosis and her staging. You can see it's seen here on the CT, and in these lesions, we like to have an approach that is sort of in line with the bone to minimize the risk of a fracture. And that sometimes requires the use of CT navigation software that we can use to get into the bone in the appropriate trajectory. And this is how we got into the lesion and got the sample. When dealing with primary tumors, it's a bit different because you have to discuss the approach with the orthopedic surgeon because these patients usually are surgical candidates and may need surgery afterwards. The main objective is to avoid crossing several compartments to decrease the size of the surgical resection. Coaxial technique is preferred, cross-sectional imaging is preferred, and marking the skin entry site. And all of these are as an approach to decrease the chance of tract seeding and hopefully improve the outcome for the patient after the surgery. So this is a patient, a 23-year-old female who had long-standing pain and a new mass in her right foot. You can see it here on the X-ray. PET CT was done showing this FDG avid lesion in the right calcaneus with the very large CT correlate. Now you can easily see this lesion under ultrasound with the cortical defect, but the value of using cross-sectional imaging is that you have radiological evidence that this is the approach that was used. We marked the skin. These are reproducible images, so if the patient ends up getting surgery 5 years afterwards, if this turns out to be a benign lesion, they can just look at the images from the biopsy and see the approach that was used. They don't have to try to interpret the ultrasound images that you take. And this lesion ended up being an Ewing sarcoma, and she had a resection. One other setting where the approach is important this example is a 58-year-old female with a left femoral neck lesion that was FDG avid and had a CT correlate. Now in these lesions in the neck of the femur or proximal femur, you try to have a close trajectory to the lesser trochanter or the trochanters to decrease the chance of a fracture after the biopsy or after the especially if it's an open biopsy. And this is where navigation software is useful to be able to get the approach as close as possible to the lesser trochanter and decrease the risk of a fracture. And this is what the CT image for the trajectory looked like after we got the sample. And I recommend this publication about bone biopsies, what radiologists need to know. It's in the AJR, and it's very valuable for young attendings and residents to get an idea of what you need to know to approach bone biopsies, especially for primary bone tumors. Now, The second part of our role is treatment, and we usually divide that into ablation, embolization, or fixation. The most common or the most well-known of our treatment approaches is ablation. And ablation is divided into treatment intent or palliation intent. This first case is more of a treatment intent. This is a 74-year-old male who had RCC, and he had a right fourth rib lytic lesion. That was the only site of disease at that time. It was FDG avid. This was the site. It was previously radiated with very minimal essentially no response. And so the patient was referred for a possible cryoablation. This is the CT showing the correlate. This is the patient's position before the ablation, and this is the cryoablation probes covering the lesion. And this is the ice ball, which is a very valuable part for cryoablation, where you can essentially see what you ablated and make sure you covered the whole ablation, the whole lesion. It is a growing indication, especially for local tumor control in patients with oligometastatic disease. Several studies are available, mostly retrospective, which is the case with most of our IR studies, but they show good tumor control, local progression control in about 70 to 80% of patients for up to 2 years, which is very significant, especially if you consider that these patients don't have a lot of options left for them. What about ablation for patients with benign lesions? For example, this 25-year-old female who had long-standing left calf pain, she had imaging which showed, I don't know if you can see the phlebolith on the x-ray, and the ultrasound showing this hemangioma. An MRI showed this low-flow vascular malformation, and so the patient was referred for an ablation to control the pain. This is the CT appearance after placement of the probe under ultrasound guidance, after initiation of the cryoablation, and I'll go through it one more time. If you can focus on the lateral aspect, you will see that there is another smaller needle that was used to hydrodissect and move the skin out of the way to preserve the skin and prevent skin injury. And this is a growing indication for symptomatic intramuscular venous malformations, where cryoablation is superior to sclerotherapy and superior to surgery, or at least better results and less invasive, with less procedure, especially when compared to sclerotherapy. What about embolization? The main approach for embolization for these patients, for cancer patients, is preoperative embolization. I know Dr. Gamal discussed that in the previous session. This is an example of preoperative spine or vertebral body embolization for a 27-year-old male who had a poorly differentiated adenocarcinoma, an enlarging L3 lesion with an epidural component. And as we go through the MRI, you see that it is relatively vascular, which is a good indication. You see the compression of the epidural component. The approach for these patients is that you try to embolize, you interrogate almost all the levels, at least 2 levels above and 2 levels below the target lesion, and you try to document every step. You go through them systematically so that you don't forget which one you injected. And then after you interrogate all the levels, you re-access the site where you want to embolize, and you protect the ventral aspect with coils. And our approach is to do liquid embolic to decrease the vascularity. And as you can see in this left L3 post-embo, there is essentially no vascularity in that lesion. And this is the image on the right side, pre-embolization and post-embolization with no vascularity. And the goal for this is to decrease the blood loss during the surgery. In our institution, we're looking at the use of liquid embolics compared to coils. Coils have dropped the blood loss from around 3 liters to around 1.7 liters. Our study has shown, it's pending publication, that the mean blood loss is about 400 cc's compared to 1.7 liters, which is a very significant drop. What about musculoskeletal tumors where there is an impending fracture or there is a fracture? We can help with fixation. This is a case of a 61-year-old female with metastatic thyroid cancer. She has right hip mechanical pain, and the assessment of the pain here is critical to identify how the patient will respond to your procedure. This is what the imaging showed. She had a very large lytic lesion in the right sacrum and right posterior iliac bone. We do this under fluoroscopy and CT and fluoroscopy. You use essentially the Madison or bone biopsy needles to get the access, get the K-wires in place, and then you insert the screws through over the K-wires, and then after you get the screws in place, you have the option to insert cement either through the screw or before the screw, and each one has its advantages and disadvantages. And this is what it looked like on the cone beam CT post. This is what the CT post fixation looked like with the screws in place. This is the sagittal recon showing the screws in place with no extravasation of cement, and the patient's mechanical pain improved significantly after this procedure. I recommend this publication I've done with two of my colleagues who are focused on musculoskeletal interventions. It's in TVIR, Techniques in Vascular Interventional Radiology, where it focuses on image-guided procedures to stabilize the pelvic girdle in cancer patients. That was all for treatment. What about palliation? Where the major role for ablation is palliation, as with this case where the 70-year-old female who had endometrial cancer had a left lower limb swelling and biological left pelvic or hip pain. Again, this was previously radiated. It's not mechanical pain, so there is no role for fixation. She had biological pain. So after assessment, this is what her PET CT showed. There is FDG avidity in the left iliac bone, left supraacetabular region. And given that, like I said, this is not mechanical pain, this is biological pain, ablation would have been enough to handle this. So this is our planning image. We did this under PET CT guidance, and we tried to target, the goal with palliation is you don't have to cover the whole lesion to get a response. You just have to cover the bone-tumor interface as much as possible. Ideally, you would like to cover as much as you can, but if that has an added risk of hurting a nerve or causing more complications, then it's always safer to do less. And this was our planning approach, and this is our ablation probes in place. Cryoablation probes in place. 2 of them were supraacetabular in that lytic lesion, trying to avoid the joint. And she got a significant response almost 6 months out of the procedure now with no pain. And during our clinical assessment, I spoke to her. She mentioned that she had left lower limb swelling that's been going on for almost 5 years. And during that time, she has run out of options. The swelling in her limb has limited her ability to ambulate. So we decided to do a venography at the same setting to do a sort of one-stop shop in the fluoroscopy suite. And you can see that the left iliac vein is essentially occluded or compressed by the tumor. She never had any thrombus in that area. So we were able to recanalize that and place a stent, and her lower limb swelling improved significantly, almost resolved over the next couple of weeks. So this is an example of what we can offer. There's a lot of literature on thermal ablation to relieve pain from metastatic bone disease. This is a systematic review that looked at pain relief after thermal ablation, 1 and 3 months out, and it showed that there was pain relief almost in 90 to 95% of patients, whether with microwave or cryoablation or radiofrequency ablation, and this is something that I think we can offer our patients. Thank you very much for your time.
Thank you, Dr. Amgad, for this valuable presentation and interesting case.